Okay, we ready to go?
Let's do it.
Well, welcome everyone. As always, we appreciate your time. ESA, Cindy, Anna, and I understand time is precious, right? So we're so thankful you're here and part of this exciting healthcare series focused on well-being, in which we will continue into what we believe is October. This is the fourth of 8, potentially 9 meetings set at a 2-week interval, where we have been showcasing to our community the best of the best innovations in well-being, who are really positively impacting organizations as they focus on attracting, engaging, and retaining talent. So before I turn it over to our session leader, Art Dickerson, to introduce Included Health and SimplePay, we want to acknowledge and thank certainly our sponsors, ADP and Siegel, and certainly specifically Art for his willingness to facilitate and moderate this discussion. ESA considers Art one of the innovators in the well-being space, and he has been instrumental in targeting solution providers who are unique and some of the best. Art is the president and CEO of Top Gear Strategies, has been at the forefront of innovation for over 4 decades, and his company advises on leading innovations and growth strategies. So with that, I will pass the baton to Art to introduce Included Health and SimplePay to set the stage for the hour that we've got together. So with that, I'll turn it over to you, Art. Thank you.
Well, thank you, John, and welcome to everybody for this 4th of 8 sessions we're having on this Best of the Best Innovators series. You know, I always like to remind everybody why we're hosting this series, because, you know, wellness and well-being are more foundational than ever for companies wanting to achieve optimal engagement and retention. And that's necessary to recruit the best in talent in the world. So we're hearing from employers like all of you that they're doubling down on new and innovative strategies to achieve a 3-fold improvement, not just on health, but behavioral and financial well-being, and doing it in new and better ways. So as you already know, for many of you are repeat attendees, every 2 weeks, we'll highlight 2 of the best. And we are today happy to have presentations with Included Health and SimplePay. They're going to provide their deep insights on their innovation that's both unique, and what I like about this series is completely unfiltered for your benefit. Just a reminder that's being recorded today, and we'll send out a link to ESA's YouTube channel with the presentations. So again, thank you for being with us today. We know your time is a valuable asset, so we're grateful you've chosen to spend the time with us. We do want to make sure that you have adequate time to learn about these leading innovators and basically help you achieve that optimal engagement and retention of your talent. So we're going to now get to move to the detailed presentation. I'll switch over to our first presenter, and just like you to introduce, Inya Spark, sorry about Inya, who is the VP of Growth Strategy and Innovation with Included Health, and also Wally Goma, co-founder of SimplePay. Next slide. These 2 presenters are going to be taking us through today with 15 minutes each. So I want to thank both Inya and Wally for being on our panel today. And by the way, I wanted to mention, Inya, that I understand congratulations are in order. You've surpassed, is it 6 million members with some great brands like Walmart and Amazon?
Thank you so much. We sure have. We have about 10 million covered lives through our employer part of the business, and over 85 million covered lives through our health plan business. So we sure have surpassed.
That's fantastic. And Wally, let me thank you too for being on here today. I know you too continue to grow dramatically with your new model of insurance. And I understand congrats are also in order that you've landed one of the great serial innovators, Dr. Eric Bricker, who is your medical director. I guess he was formerly with Compass Professional Health Services, I believe. So moving on to the presentation by Inya, you can go ahead and share your screen. According to our format, you have 15 minutes and thereafter 10 minutes of Q&A. I will cut you off at 15 minutes sharp. Inya, please share your screen. Thank you. And you've got 15 minutes. Take it away.
Well, wonderful. Thank you so much to ESA. Thank you to you all for joining this morning. As Art said, I'm Renya Spock and have the privilege of spending the next 15 or so minutes with you. Let's go to the next slide, please. All right, so you may or may not have heard of Included Health, but you probably do know our predecessor organizations. Included Health was born from the merger of Grand Rounds and Doctor on Demand. Grand Rounds was the leader in navigation, steering to high quality in-network care, expert medical opinions, and helping members navigate the complexities of the healthcare ecosystem. Doctor on Demand was an organization that is and was the leader in virtual care with everyday and urgent care, think traditional telemedicine, virtual behavioral health, and in fact was the first to market way before anyone thought of a pandemic around virtual primary care, really creating those longitudinal relationships between patient, member, and our employed physicians, and really managing and working with them in a traditional primary care relationship that happens to be virtual. When you bring these two organizations together, Included Health was born, and we really believe that this merger creates truly a new innovative category in healthcare that sits at the intersection of helping people navigate to care and their benefits, providing whole person care, not just physical health or emotional well-being or dissecting them into various point solution condition areas, but really creating this category of navigation meets true virtual care, all coordinated in one platform, in one system, and in one integrated experience for the member. We believe that this is the future of healthcare, this hybrid model where you're seeking some care virtually and it's well coordinated with the care that you need to seek in the community, all coming back to one integrated data connected ecosystem. And so I'd like to bring that model to life for you with an example so that I stop using industry buzzwords and just show you what that means from a member's perspective. Let's go to the next page, please. And I'd like to introduce you to Meet Irene. When I first saw this, I worried because while my name is Renya, my real name is Irene. And so I thought, oh, is this me? And actually it's not. I'm happy to report I'm not quite 45 and I don't have diabetes, but meet Irene, who is actually one of our members from one of our large retail customers. Irene is 45. She's just come out of the hospital after 2 weeks stay for really severe hypoglycemia. She is a diabetic. She is struggling to manage all of the pieces of her diabetes, but the issue is her life and her experience with diabetes does not end with her condition. She has a lot of personal distress going on in her life. She lost her mother during COVID and her husband was just laid off. And then you layer on top that she has really significant health challenges. So her life and health has just been hard to manage. There are all these pieces of her sort of condition to manage, but then all of these other pieces. And if we tie this back to the really focus of today's discussion around human capital and well-being, these issues for Irene are equally impacting Irene's employer, as Irene simply can't be focused on her work day to day. She's been out a lot. She's missed work. She is not focused. She's not productive because of these broader issues impacting her. When we spoke with her employer, our customer, not about Irene specifically, but about this profile of Irene, the concept of job lock came up, which I think is a really fascinating one. And in this context, job lock was referring to high risk, high cost cohort of any workforce who is actually less likely to leave because leaving and changing jobs introduces new risk, needing to perhaps change a provider, needing to meet a new deductible at a new employer, having gaps in coverage. These are things that the Irenes within a workforce really can't bear to take on that risk. And I think that that's a really important consideration when building a future-proof, innovative well-being strategy, is realizing that there are some attributes of the workforce that make them uniquely important to focus on. Let me tell you what we've done for Irene on the next page. So I'm just going to tell you the story. Don't worry about all the words on the page. But Irene has access to included health because her employer purchased us. We reached out to Irene when we noticed that we use claims data and other analytics to identify that she just had a hospitalization. She had no evidence of a local PCP that she was working with consistently, and lots of gaps in care. When we met with her, we learned that she was out of her medication because she couldn't afford it. She also had uncontrolled blood pressure and elevated A1C. Those are not things that show up in claims. These are things that show up when you talk to a person and you build trust with them and they begin to tell you about their health and contextualize that health issue. We realized that she needed a new primary care physician, and for her, the most convenient and appropriate thing was to have a virtual PCP, which was an employed physician on our team who was starting this longitudinal, ongoing relationship with Irene and really holding her hand and coordinating her care that we were delivering and the care that she needed in the community. Through regular follow-ups, we helped her get back on her medication management and also educated her about the other pieces related to her diabetes. When she needed an endocrinologist in the community, because we've reached the outer bounds of what we can do virtually as her virtual PCP, we used our algorithm to find the highest quality in-network, best match endocrinologist for her and coordinated all of that care so that's not happening on a silo. We also learned that she was dealing with some depression from all of these situational things happening. And she started a virtual behavioral health series of sessions with us, all coordinated on our platform, one patient profile, all knowing all of these dimensions of Irene. We learned that when she needed to go to that endocrinologist appointment, she actually couldn't afford the gas in her car at the time. We have a partnership with Uber. We coordinated the Uber ride for her. We got her to the care that she needed and continued to manage her through the situation. I wanted to bring that to life for everyone because this is how healthcare, we believe, should exist, this full end-to-end, whole person, coordinated, intuitive, and personal experience. And this is what we're doing. We can sell and service any one of these elements as a standalone offering, but for us, when you put them all together in an offering that we call all-included care, we're really transforming the industry and meeting Irene's expectations for how she should experience healthcare. Convenient, personalized, high quality, reducing barriers and friction to care. Let's keep rolling after I've just shared with you about Irene and why Irene's employer and hundreds of other employers and health plans have elected to work with us. There are three dimensions. One, first and foremost, so many of our customers come to us because of our guaranteed ROI around both our program. And when you buy all of those pieces I just described, also commitments around trend guarantees, total cost of care mitigation, and overall trend savings. Other employers come to us because they have segments of their workforce who simply don't have access to high quality care in their communities. They know that. And they're looking to really drive people to the programs, the point solutions, the offerings that they've invested in. And so really helping to get people to the appropriate care, services, and benefits that are offered. And I've put a big blue box around this last piece because I think it's so central to this webinar, but really to so many of the conversations we have with our prospects and customers today. They come to us because they need to create a truly differentiated employee experience to attract and retain talent. And being able to differentiate on healthcare with innovation here and offering a benefit like what Irene just had is really something different. So with that said, let me just contextualize a little bit more about sort of who we are and what we do on the next page. What I'd like to emphasize is that we have solutions for every need along the healthcare continuum. And those things, as I mentioned before, can be purchased separately or they can be purchased as a bundle, as all-included care. Most of our clients buy us for a full population. We are hired for all of ARC-BEST's population. I'll use an ARC-BEST story in a moment. But we are hired to help with the administrative needs, employees needing to find and understand a health benefit, or what is that point solution I heard something about, or how do I take the next step in my health, or I can't understand this confusing EOB I got. And then if we move to the middle of the continuum, this is just a remote worker who is looking for access to a primary care provider, and maybe they can't find someone in network in their community that can see them or that they have a good relationship with. And so we're either helping them find that person in network, or we're becoming that virtual PCP for them. And then all the way on the far end of the spectrum, all the way to the right around complex, because of our depth in clinical and the fact that we employ all of our physicians, we are helping people navigate to the right national expert for rare diagnoses through expert medical opinion, and then doing all the things in between. So we are guiding, we are improving access, and we're in the business of delivering care. And all of this is done on one platform, one experience. And for me, the innovation here is around reducing the fragmentation that has historically defined the healthcare experience. We go to the next page, just a quick statement around tying this back to well-being and human capital planning, human capital strategy. As we work with our clients and work with their full population, we know that there are underserved segments of any workforce for whom they've been either discriminated against or simply can't get the kind of care that they need to meet their situation. We've built these offerings which can be implemented as standalone. You don't need to buy anything else from us. It's called communities. We have one community for the LGBTQ+ community, and we have another community for Black health. These are offerings to help members of those communities navigate the unique, specific, and unmet needs that face them in their efforts to navigate healthcare. These are teams that are separate from the rest of our teams. They are teams staffed with individuals who are members of that community, who have unique and special tools to enable them to help members of LGBTQ+ or the Black health community navigate their unique challenges in facing healthcare. Quickly about ArcBest. If we go to the next page, let me just sort of tell the story. To me, all of this is great and interesting and I believe innovative, but so what if people don't use it? And when you think about who are the hardest populations to engage, and engagement being the make or break of any one of our programs, think about an organization like ArcBest, who has people driving trucks all day and in warehouses and not in front of computers. We've worked with them to roll out the services I've described today. And I think really this notion of creating a virtual person-centered medical home is really a central piece of what has resulted in the impact I show on the right. So more than a third of registered members have had a virtual PCP visit with us already. Over half have engaged on multiple visits. All the while having 5-star ratings from members who use that service. And I'm watching the clock, Art, and know I'm 1 minute away from the hook. And so I will keep us moving, but I just want to bring home the point that doing this on paper is great, but engaging people in these programs is what really matters. And to be able to do it with a traditionally unengageable workforce is really some of the innovation I think we're bringing to the market. On the last and final slide, I just want to make mention of an innovation that we're working on that really ties to workforce planning and human capital. One of our large franchise organizations came to us and said, we cannot make our workforce, this segment of our workforce, benefits eligible. We can't afford it. We don't want that to happen. And so we came up with a model that's actually a perk, not a benefit. And as benefits professionals, we sort of know that distinction. It's not having an impact on ERISA. It's not having an impact on ACA. It's not having a COBRA impact, where we are offering a 10-pack of virtual care visits to the non-medically eligible, non-medically enrolled population that they can use as a convenient way to access physical health or behavioral health services in a pack of 10 over the course of a year at their discretion, all done virtually without making an actual benefit. And I bring that up because I think it's so key as we think about workforce planning and the future of well-being for an entire workforce, not just for those who are enrolled in the benefit. So with that, I'll cut it there, and thank you so much for the opportunity for presenting. My contact and our contact information is on the page, and I look forward to answering the hard questions Art and others will send my way for the next few minutes.
So, thank you, Rena. Stop sharing your screen. There you go. So attendees can be seen if they want to ask questions directly through the chat function. So sorry for putting you under such time pressure, but you were right on time for the 15 minutes. So good job there. A reminder to all those on the webinar, you can click on the raised hand feature if you're so bold to be on screen, or you can just ask questions through the chat function, and we'll ask as many of those as we have time for the 10 minutes. One of the questions that may be in someone's mind saying, how does this work with a health plan? It sounds like some of the things that you're doing are performed by a health plan. Can you share how that's all coordinated in that regard when a company has your services as a separate a la carte program?
It is a wonderful question. As I mentioned, we have services that we call all-included care, which are all of those pieces in, but by design, we have built our solution also to be modular. And with that modularity comes this notion of carrier compatibility. So we have, in fact, most of our clients remain with their health plan, and the health plan does core functions, of course, claims adjudication, network development, overall, all of the insurance functions, and in many of those clients continue to do care management services and may even continue to do member services. We become another number on the back of the ID card. We don't have to replace those services. For those employers who have purchased our full-in, all-included care, we often are actually replacing some dimensions of what a health plan does, but not the core services. And so that too, in many ways, is carrier compatible. We work on integration with the health plan, and as we've done with Art Best and hundreds of other clients, to make the win-win where we're getting the best pieces of both organizations in service of our shared client.
Gotcha. Well, thank you. People ask the question sometimes, gosh, it sounds like it's really interesting. And you talked about this 10-pack, I think. So is there certain industries where it fits or doesn't fit? What about group size? And also, if you buy a bundle versus you buy the pieces, how's that priced? We're just talking, obviously not firm quotes for this thing, but some general guidance on matching up your services against many of the members of this audience.
Yeah, fantastic. So let me start with the most macro question, and then I will answer the 10-pack as well. But in general, our services are priced on a PEPM or PMPM basis. For the virtual care component, that is additional visit fees, which run through claims. And depending on the services that are purchased, it could be anywhere from $1 to $20 per employee per month for the all-in pieces, but there are also things that employers can turn off or find savings from. And so it's not all net new cost and spend. And so that is our general pricing. For the 10-pack, which is this new innovation, we are starting off bringing that out to our franchise businesses. So our country's largest food franchise, you can make some guesses of who that is, has been the first co-innovator with us around that. The pricing model for that has a mechanism where it's actually charged to the franchise owner and spread across the eligible population. So those members actually aren't paying anything for that service. And then we have variable ways to sort of do that. Let's say you want to charge $5 for the year or some nominal amount to have skin in the game for those employees. You can do that too. And so we have great flexibility in that 10-pack sort of virtual care bundle model as well.
Great. We are opening this up for a couple more minutes of questions. If we have any folks on the line that would like to ask another question about Renya.
I see Rick has asked one, and maybe
about your career journey.
Yes, about Irene, the journey of Irene, and how did Irene come to our attention? So there are multiple ways, one of which in this instance, because Irene has healthcare claims, right? She is in the system, she's utilizing, she had a recent hospitalization. We do get claims data, and we are running our algorithms in real time to figure out who we need to outreach to. Some of our clients don't send us claims if they have a smaller package with us of offerings, and through a variety of engaging upfront things in our app, we learn about the member, we learn their preferences, their needs, and that will spark reasons for either us to reach out to them, or equally important, them to reach out to us when they have a question. And so Irene's employer had no visibility or contact into what's going on with Irene or with us, and was not specifically involved in, the person level outreach, but certainly was involved in setting up the infrastructure from a claims flow perspective as we collaborate with their health plan.
Well, certainly a 11 A1C is a train wreck. So can you comment for the group about how many of those you typically might experience on some kind of denominator basis in a population? We're going to see 1%, 0.5% of a workforce.
Yeah, it's a great question. So, when we think about stratifying a population, the true Pareto rule holds in terms of small number driving the large amount of spend. What we have found, and we do put resource and time disproportionately against that top 5% of a population that are acute to catastrophic, incredibly complex. And that is where a lot of our energy goes. But we also are working on engaging the full population, because our model is really built on building trust between our organization and the patient. And you build trust when the stakes are lower, right? Or you can build trust when the stakes are lower. You're adding value. You're helping with the EOB or the bill. You're helping find a great in-network provider. You build trust, and then you harness that trust when people begin to experience more complex needs, where you're really able to steer them and harness that trust to really guide them to the right healthcare decision that may or may not be either what their initial treating physician had suggested, or may not be what they want to do because it's the hard thing to do, but it's what they need to do to take control over their health.
And I circle back to a question, I'm not sure we got to the heart of that, was is there a minimum size employer? So no, while this group is largely large employers over 1,000 lives, there are people that have connections with other companies that might be smaller. So is there a threshold? Does it vary by product that you offer?
It does vary by product, but I'd say the lowest is about 1,000. We have made exceptions with some of our broker partners who we work with very closely, where they have a smaller group that for all the right reasons, exceptions are made, but in general, 1,000 is really the floor.
Great. And I'm assuming the 10-pack with the franchisees allows you to reach to smaller customers, but because you're doing it on a group basis is how you're able to deliver that to the food distributor.
You got it.
Right. Well, we have another question. Rick is prolific, I think, in his questionings. Do you measure and monitor health risk factors of the organization's employees, and how are those factors then, how have they changed, I think is what you're asking there, Rick, right? Have the risk factors the employees of your organization clients fallen?
Yeah, I guess I'm looking for trends, as people engage your services and you're measuring the health risk factors across a population of employees, can you notice declines in these health risk factors?
Yes. The answer is yes and yes. And in fact, that all flows through to our performance guarantees. So we put our money where our mouth is. We have very robust reporting led by actuaries who we have hired from some of the large consulting firms and beyond. And really a very comprehensive reporting package that looks at leading indicators and lagging indicators, progress over time and changes in population health at the metric level, benchmarking against industry and our book of business. And it's those results that we produce and report out in our annual and quarterly reporting that then translate into our commitments from what we promise to deliver from a population health management improvement perspective, from a cost perspective, from a quality perspective. And so metrics across that entire portfolio of categories are all part of our reporting and our transparency.
It would seem to me that not only would this be extraordinarily valuable to the employer, but to the insurance carriers. Do you have any carriers that are funding the bill for the services?
Yes, we do. We have a very robust health plan business. In fact, 85 million Americans have access to one or more of our services through a health plan, not directly with us. And across that health plan business, we have some health plans where we are implemented in their fully insured business. So they're footing the bill. We have some that are applying this to Medicare Advantage, and we have others where it's more of a sell through to their commercial population with various, promised integrations, but they're not footing the bill.
So Rena, I
Thank
think would you say it's the doc on demand that gave you the greatest reach in health plans? For that,
Yes, that is
telehealth?
true.
Yeah,
Yep,
yeah,
that
got
is
it.
true.
Great. Well, listen, thank you, Rena, and I want to get on to Wally. Wally, you're up next, but you did a great job, and we appreciate you being on the panel. Just a reminder again, the presenters or us at ESA if you're interested in engaging with either Wally or Rena, feel free to reach out to them once the materials will be circulated through the YouTube channel, and it'll have their contact information on it. Wally, I know you've been sitting there patiently, and so you want to go ahead and share your screen. You
Yes,
know that
sir.
really you got 15 minutes and 10 minutes QA, and I'll cut you off sharp. So begin.
Very good. Well, again, thank you, Art, and to the ESA for the opportunity to share with you a new model of insurance that was really designed to try to deal with cost and complexity in a meaningful way, facing the medical insurance industry. As we unpack a little bit of how this model works, I think you'll see some new benefits that have been integrated for the first time into medical insurance, into employer-sponsored insurance that can also be used to attract and retain talent to an employer. And as we go through this, obviously, please ask questions along the way, and we'll have time to cover them as we go. One of the big motivators, and you see it in the name of our business, SimplePay Health, was to really deal with the complexity facing plan participants and employers, plan sponsors, when we think about insurance coverage. This is a study I would commend to you, the Global Brand Simplicity Index. In every year that we've looked at this study, health insurance is always ranked at the bottom as the most complicated industry that we would interact with as Americans. And that's obvious for many reasons, right? There's confusing plan design terms that only about 4% of plan participants, if you give them the terms deductible, co-insurance, copay, and out-of-pocket maximum, only about 4% can actually match the terms of the definition. And then there's all the confusing paperwork, the many bills that we receive from providers and explanation of benefit forms from insurance carriers to try to sort through who to pay what to. And when we designed SimplePay, I like to admit we really didn't invent anything. We basically created a patient journey, a process that effectively lets your health insurance work the same way it does whenever you buy anything in the real world. But the goal of the model is not only to simplify for the sake of creating a better experience, but it ultimately is to naturally self-motivate individuals to choose higher quality providers that are available in their community. And I would tell you that in his 30 years in the industry, working on all sides, the provider side, the insurance carrier side, the consulting world representing large plan sponsors, this next generation of quality transparency, helping patients align with the top quality providers in their community, we really feel is the next frontier of opportunity inside of our industry. So how does it work? Let's assume a patient was going to have medically necessary knee surgery. We're going to walk through 3 steps that should feel very natural because it's the way we buy things in the real world. If a patient was having medically necessary knee surgery, we're going to provide the patient with 2 pieces of data that we believe they should have had years ago around quality and around price. On the quality side, I like to say nobody has to go to open enrollment to know that 5 stars is better than 3 stars or green is better than red. We're not reinventing the wheel. We're drawing from the universe of available data to provide the patient, the plan participant, with credible information that allows them to see side by side how does provider quality differ. This data is drawn from one of the country's largest claiming quality data sets. We measure data across 130 million studied patients, many billions of claim records to be able to create credible scorecards on quality. But if you look at the smartphone on the left, probably the #1 thing we heard in our focus group testing as we were designing this model was patients were pleading with us. Can you just tell me before my knee surgery how much I'm going to owe? And the problem with current plan designs, which include deductibles and co-insurance, is not only do plan participants really not know how those models work, it prevents them from being able to understand exactly what their price is going to be out of pocket before they go. So what we did in this model is we just eliminated that. We got rid of deductibles. We got rid of co-insurance. I like to say you don't have to have a deductible to buy other things in life. Why do we have to have it in healthcare? Now you know exactly what your price is going to be. It's one flat copay out of pocket. And the way this model works is we essentially assign lower copays to providers that have been designated higher quality. We really thought that was going to be enough. If a patient knows the price out of pocket to them ahead of time, this is their fully loaded cost. It covers the hospital, the surgeon, the anesthesiologist. We really thought that was going to be enough. You know your price, you know your quality. But the problem is that patients could never figure out who to pay what to when all those bills and EOBs came in the door. So in this model, when you show your ID card, as you see, we are partnered to make this model available on a national level in partnership with Aetna. Aetna will actually reimburse the provider their contracted rate in full. And in this model, patients never have to worry about paying doctors, hospitals, or pharmacies ever again. Providers are paid in full, just the same way that if I bought something with my credit card from a retailer is paid in full by the credit card company, and then 30 days later, you get one monthly statement. Now, when you show your medical insurance ID card, providers are paid in full the way that I believe they should have been paid all along, and patients receive one simple monthly statement from their insurance company. So to kind of think about these three steps, you will know your price ahead of time to the penny. No more guessing and wondering what something's going to cost you out of pocket. We call it price certainty, better than price transparency. You have information on quality, price tags will be lower for higher quality providers. And instead of trying to sort through the many bills and EOBs we have to spread across our kitchen table, providers are paid in full, and the patient gets one simple monthly statement, and the price on that statement will match the price they're going to see earlier. Again, if you think about how we buy things in the real world, you know the price, you get one statement. This will replicate that approach, and will naturally motivate individuals to choose higher quality care, as you'll see in a moment. That's the real opportunity. But before we go there, I want to introduce another challenge in our industry, and that's the affordability challenge facing many Americans as it relates to being able to pay their out-of-pocket cost. In my knee surgery example, there's a $750 copay that covers the cost of my knee surgery. And for many Americans, they don't have the disposable funds to be able to afford it. On a good day, we might be using high interest rate credit cards or taking out, a payday loan. But unfortunately, for many households, they avoid necessary healthcare services because they don't have the financial means to be able to afford the out-of-pocket cost. And after college student loans, healthcare is the second largest category of consumer debt in the country and the leading cause of bankruptcy in the country. We really felt it was time to introduce a new financial well-being benefit to really help Americans bridge through the affordability challenges in healthcare. So when an individual receives their monthly statement, they have options. They can choose to pay in full, or they can choose to pay over time with a revolving line of credit that allows individuals to pay over time without having to resort to high interest rate financing or to avoid needed health care. So if you can imagine how this works, your monthly statement comes in, you can choose to pay in full, you can pay the minimum amount due, doesn't require a credit check, and at no time is there any cash flow or collection risk back to the plan sponsor. It's a true financial well-being benefit now included in health insurance in a meaningful way. So to kind of close, I'll tell you what we've learned over the years is that if we can get rid of insurance complexity, give the plan participant a low, medium, and high copay up to an out-of-pocket maximum, explain to individuals that a lower cost to you doesn't equal lower quality care, explain why in healthcare, higher quality actually generates less healthcare resources. What we've seen is that the engagement rates and the shift towards top quality, it dramatically exceeded our expectations. For most employers, we will see about a quarter of the paid claims are being delivered by top quality providers in the year before we implement this plan design model. We implement simplicity and the voluntary shift towards quality. It doesn't double. We actually see that it will triple or better, with 86% of paid claims moving to top quality providers. That voluntary shift, that engagement, without narrowing the network, without reducing choice, without shaming anybody to go to certain providers, this is just the power of consumer behavior, aligning with top quality. In addition, this is the first time in my career that I actually enjoy going to open enrollment and presenting a plan change. It's a very powerful message that can be used to attract and retain talent for a simpler insurance model to employees and their families. You will always know your cost. No more bills or EOBs. One simple monthly statement supported by a white glove concierge. And not only will it help you as a family spend less money out of pocket, more importantly, it will align you with higher quality care. And, obviously, as we were designing, a next generation health plan model, we wanted to also include a number of clinical solutions. There's an ultra high touch care management model supported with a number of health and well-being tools that are automatically included. We don't charge admin fees for these services. They really flow through as per use medical claims if someone participates. And I will just close and tell you that I think this is a really exciting time for our industry. Having been around for many years, we're excited about new alternative health plan models that are coming to the industry. There really hasn't been anything that meaningful in plan design since high deductible health plans were introduced into law in 2003. And our organization, along with others, are looking for new and innovative ways to create better health plan experience for plan sponsors, plan participants, and even for providers. So Art, I will probably hit the pause button here, and I think we have some questions that came in and may try to help get your help to facilitate those as we go through.
Yeah. Thank you, Wally. You can stop sharing your screen so we can see the attendees as they ask questions. One of the things that came to my mind as I was listening to you, Wally, we had to have a federal law passed to have no surprise billing eliminated. And it sounds like the federal government should have just come to you for that. So, and having this, and I'm thinking about July 1, just a few weeks ago, all the machine readable files are coming from all the carriers, and who knows how that's going to be presented to help people understand costs. You surely, it seemed like you've worked this out in a great way.
We kind of, let me take the surprise bill part first before we talk about the transparency laws that are moving forward. I will just tell you, I think every bill in healthcare is a surprise bill. A lot of the legislation is really to deal with out-of-network surprise bills from providers that aren't, part of an insurance network. But no one really knows what you're ever going to owe ahead of time. So we just disconnected that. Patients will always know their copay. It's done at the place of service level. So if you go to a doctor's office, it's one copay, whether it's just an office exam or whether they do an in-office lab test or an EKG. Your copays, our whole thesis was you can't be a consumer of anything unless you know the price of everything ahead of time. So patients will know their cost ahead of time. Again, we try to move this beyond calling it price transparency. What patients really want to know is not the contracted rate between the insurance network and the providers. They just want to know, what does it cost me? Just like when we buy anything else in the real world, it's human behavior. And so by disconnecting the provider reimbursement from the patient responsibility, now patients have that price certainty. And I think we really step even further and beyond, some of these machine readable transparency files that are going to be moved around that don't really, in my opinion, get to what patients are really looking for.
I wanted to get one question on the table before we run out of time about the quality. Is quality truly quality, or just do some physicians serve sicker patients, right?
So I debated with myself back and forth whether to show on our screen the way we measure quality. I will start by commending to you a book by Dr. Marty Macri from Johns Hopkins. He's a Johns Hopkins surgeon, and really I think is given a gift that should be read by everybody in our industry to what's really going on in medicine as it relates to quality, efficiency, and how does financial motivation, create, excess cost and waste in the system. So I would really commend that book to you. In our model, we're a spin out of, one of the country's largest patient navigation businesses. My co-founder and Dr. Bricker, came from the organization Compass. They sold that business to Alight. Today supports, millions of plan participants, really helping them navigate, towards, better quality care. And that data set has continued to grow over the years. And I think it's obvious to our industry today that there's differences in quality. We just didn't have, the design and the insurance model that would create simplification so individuals would be naturally self-motivated. We work with Aetna on a national level to make this available. And obviously they have been measuring provider quality for many years. In some markets, we actually work with Blue Cross. So it's really taking advantage of, I think, what our industry knows and sees, but putting it into an insurance model that allows us to lean in. We do look at quality. We look at efficiency, meaning is a provider, ordering excess wasteful services when, they're ordering surgery when therapy should be indicated. We look at complication rates. We look at outcomes, appropriate outcomes, by the way. Just because a surgeon has great outcomes, it may be because they're operating on healthy patients. And we will look at unit cost when everything else is said and done. So it's a comprehensive model measuring across hundreds of data points and many billions of claim records.
You didn't mention this, but the service that you're using for the data on quality typically is driven based on risk factors that are placed, on the level of acuity, I should say, based on the patients in that doctor's practice. So it is a qualitative and a quantitative measure typically.
It is, and I would just tell you, we have to kind of throw out the old playbook on high performance networks. In my humble opinion, every hospital is going to be top quality for some services, average for others, and for some we may want to go somewhere else. There's no such thing as a hospital that's great at everything. I was a hospital executive in my past life on the finance side, and one hospital may be the best in town at cardiology. They may be okay at orthopedics, but not the place to go for oncology. So we have to be honest about, how do we measure quality and really help patients navigate to the best based on their clinical need. And that's basically what's gotten designed into the model.
So one more question, are physicians receiving a smaller fee for quality services?
Can you imagine how hospitals and doctors react to being paid in full with no need to ever bill and collect patient responsibility and deal with bad debt ever again? And there's no catch to it. Providers are compensated or reimbursed their Aetna or Blue Cross rate, their contracted rate in full. They don't have to ever worry about billing and collection and bad debt. They get to focus on practicing high quality care, and we will handle the patient collection in a way that works like any other industry. Again, I like to say that we're finally catching up to the rest of the industries in the real world. And we're really trying to create a better model that gets rid of the insurance complexity that is long overdue.
For those of us like me that was doing consumer directed plans in the late 90s, the absence of data on, what services cost was a really big impediment to the advancing of those types of plan designs. And then even when tools became available, it was really a statement on something you said earlier, that the majority of people are not shopping for the cost because of healthcare literacy. And I think the fact that, as you pointed out, healthcare is the bottom of all those industries. I expect you to say something about Net Promoter Score. The Apples of the world and the Ritz-Carltons around 70s, and health insurance industries historically 18. So not a lot.
Art, I can tell you, I don't know 92% of people that like anything about their health insurance. So, our reaction that we get from our clients is significant. as we roll this out, many of our clients actually select to implement this plan design and payment model, not for the financial savings. The financial savings are meaningful, but they do it in order to attract and retain talent. It really will create, hopefully an experience that we can be proud of.
Well, that's great. Any other questions by the group? We'll close out a little bit early if we don't have any other questions, but.
Art, I didn't want to get the hook today, so I was trying to be true to the 15 minutes.
Well, you did well. You did well. So I think that you've presented a great service to the average American who just wants this to work and be easy. Well, thank you, Wally. That was a great job. I want to just try to wrap a few things up here, and then I'm going to turn it back over to Anna and John. That why are we doing this? I mean, we want everyone to learn something new every time we have one of these sessions. Wally's just made the point pretty sharply that healthcare is complex, it's hard to navigate, literacy is low, and that's why we've had these two presenters on today to show you how to take that difficulty out of the process. Included Health is a great service providing a coordinated experience with 24/7 access to top doctors. They're very compassionate, and I think, as Rena pointed out, they provide services to both mind and body care, which is a growing need with the post-COVID world that we live in. And as Wally pointed out, SimplePay really improves employee well-being because it just reimagines the way healthcare works, and it brings real consumerism to the table in a way that actually makes employees happy. And happy employees with happier outcomes, means more employees are retained, and they're going to tell their friends and colleagues to come work with them, right? Because they got a great health plan. So it's really both Included and SimplePay, just great services to the public. One last thing, we're going to send out a link to the YouTube channel with all the presentations. So again, we encourage you to reach out directly to the presenters, get the contact information in their presentations if you want to learn more. Anna, John, back to you.
Well, thank you, everybody. Such great presentations and much needed solutions, and on both sides. And Wally, I got to tell you, I've been one that's been talking about what you actually made happen. I've been talking about that for a long time. So thank you for figuring it out and cracking that safe, because that's a hard one to crack. But thank you to both of you. We really appreciate it. And as Art said, we will be sending out the PowerPoints as well as the recording, and it will go to everybody who registered. So if you have a colleague who wasn't able to dial in, they will get it as well. And you're welcome to share within your companies or whatever you choose to do with that information. And we have another 2 companies showing up on the 24th of August, Castlight Health and Omada. And we are looking forward to continuing this series. So thank you so much for joining us today, and appreciate all your time. Thanks so much.
Thank you.